Okay, so let me erase this off the board. Okay. Now, in the CPT book, here you have, you're going to have evaluation and management. Management codes. Okay. They go from 99201 to 99999. Okay. Now these are all of your office visits, whatever that is. Okay. It could be for a physician office. It could be for a hospital. It could be for home health. Okay. Skilled nursing facilities, rehab facilities, okay? All those constitute for your different office visits, okay? And you have to know how to use your place of service code. So we're going to look at that in the back of your workbook. I'm going to show you that, but then I want to Google how it looks like in the CPT book, okay? Then you have your anesthesia codes. Okay. Your anesthesia codes, I think they 01000 to 019999. Okay. Now these are like for your anesthesia doctors. Okay. These are for your anesthesia doctors. And these have their own modifiers. Okay. And their modifiers are known as P modifiers. Okay. And P modifiers tell if this is a high-risk patient for anesthesia, if this is a high-risk patient but they're morbidly obese, or this is a high-risk patient because they have a lot of illnesses, they have congestive heart failure, they use a P modifier if they're over a certain age limit, if they're under a certain age limit, and they also have a P modifier if they are having that person sedated under anesthesia, but they're trying to extract for transplant reasons. Okay, so sometimes they still have to have that person under their body under anesthesia, breathing on a respirator, on a machine. They have to constantly keep that body pumping and moving for circulation reasons, but also to keep that the organ that they're trying to remove out to give to a live person, they have to keep it fresh. Okay, so a lot of times they will keep a person under anesthesia. Even though they may be a person that's deceased already, they will still keep that corpse under ventilation for that reason. Okay, to keep the cells alive. Remember how we convert things to a body? Everything starts from a what? A cell. From a cell to a what? A tissue. From a tissue to a what? An organ. From an organ into what? Body systems. Okay, so everything that has a cell is a life, and you have to keep it sustaining life even under anesthesia. Even if that person has deceased, you have to still keep them sustained life under anesthesia. And there's a P modifier that recognizes that. Okay. All right. Now, you have your surgery code. Okay. Your surgery code. Now, your surgery codes go from 10,000 to 69999. Okay. Now, this is where the subcategories go. Okay. Now, you have the and there's a proper category. Let me Google it so I can be correct about it. I don't want to just put anything up here. Let me Google it. Ooh, that is so pretty. Isn't that pretty? I love the different screens. You see it too? I just love it. I love nature. I love it. Okay. Just a minute. Oh. Okay. Okay, there we are. Okay, I know that. I need the subcategories of anesthesia. That's what I need. Subcategories. Surgery. CPT. Oh. I know it's there. What is the subcategory? Okay. Okay. Oh, I didn't have enough. That's okay. So rather than writing it, I just made y'all copies. Okay, now, okay, so for needle aspirations, do y'all see that? Mm-hmm. And I'll email y'all the link so y'all can look at this because it looks hyperlink in blue. Yeah. Yeah, so it gives further detail. Oh, this is so good. Y'all don't like this. Okay. So let me go back. Just a minute. Okay. And then, so it gives surgical procedures on the integumentary system, the musculoskeletal system, respiratory system, cardiovascular system, the hemic and the lymphatic system, the mediastinum and diaphragm, the digestive system, the urinary system, the male genital system, the reproductive system. So, of course, it's going to talk about that in general. Intersex surgery, surgical procedures on the female genital system, the procedures on the maternity care delivery, endocrine system, nervous system, eye and ocular and DEXA, procedures on the auditory system, and operating microscope procedures. Those are like your robotics. Okay? All right. Now, going back to where it says the cardiovascular system. Okay? Now, you have the hemic and the lymphatic system. That's going to be like your subcategory within the cardiovascular. Okay? So kind of make a note of that. That's your subcategory within the cardiovascular system. And then you also have mediastinum and digestive system. So some of them are going to have subcategories in there. But that one I wanted to point out to you. Okay, so your procedure codes, if you're going to work for, again, for a surgeon, you know, surgeons are certified a little differently. Some have a broad certificate, a licensure to be a surgeon, and some certified to just operate on certain things. Make sure that they are, if you're billing, make sure that they are within their scope of practice. Okay, so I just wanted to put that up there, but I'll be having to write everything. Okay, that kind of helps me out a whole lot. Okay, so let's go back. Go back to the other one here. Okay, so now
part of mine didn't print on after surgical procedures of female genital system.
Okay.
What was the next one? They kind of cut off a little bit.
Kind of cut off a little bit.
Delivery. Maternity care.
Oh.
And delivery.
Okay.
Yeah. Sorry about that.
And then you said endocrine was also on there?
Endocrine.
Okay.
Yeah, and then the nervous system. Is it on your cell? Okay, okay. Endocrine system, and then you have the nervous system. The eye and ocular and DEXA.
Now I got those.
Okay. What about the auditory?
Yes.
Okay,
It
and
was
the
just-
micros.
It was just those of the eyes and ocular.
Okay. Okay, sweetheart. Okay, gotcha. Okay. So now radiology, 710. Radiology. Codes. Okay. So you got the 70,000 to the 79999. Okay. So all of these dealing with surgery. Okay. And then you have this deals with radiology, inclusive of radiation and all that other stuff. Echocardiograms, EKGs, ECGs, EEGs, all that stuff. Okay. Then you have pathology codes. Okay. They're from the 80,000s to 89999. Okay. And then you have medicine, right? Yeah, that's what I thought. Medicine. Medicine is 9281, but I rather put 90,000 to 99,199. Okay. Now, within the medicine codes, within the medicine codes, you have chiropractic codes, physical therapy, occupational therapy, speech therapy within that. The chiropractic codes begin at 9,700, okay? Physical therapy, I forgot what that is. But I do know about the chiropractic codes. I think chiropractic goes from 98 here. 9,700 to 98. I'm sorry, 98,000 to 97,000. Okay, so if you're going to work for a chiropractic doctor, where they do these different manipulations, they work with lawyers that do auto accidents, things of that nature. Sometimes they do naturopathic medicine as well, and they help out with naturopathic type things. You know, you can code for that. Some things they won't cover under chiropractic, and most things they will. So you have to really be on top of your verification of insurance. Okay, really be on top of that. Okay, so here you go with those codes. All right, now let's look at category 1, 2, and 3. To improve, I'm on page 160. To improve the existing CPT-4 coding system, a CPT-5 project was implemented. It is a revision of CPT-4, includes 2 new code sets, category 2, which are intended for performance measurement, and category 3 codes, which are intended for new and emerging technology. Existing CPT codes are considered category 1. Category 2 codes describe clinical components that typically may be included in E&M services or clinical services and do not have relative value associated with them. They also describe results from clinical laboratory or radiology tests and other procedures Identified processes intended to address patients' safety practices or services reflecting compliance with the state or federal law. Category 2 appear in a separate section located immediately after the medicine section. They also have an alphanumeric identifier with a letter in the last field, such as 0502F, which is subsequent for prenatal care visit, to distinguish them from the Category 1 codes. Two modifiers are used to indicate that that service specified by a performance measure was considered, but because of either medical or patient circumstances documented in the medical record, the service was not provided. So modifiers 1P, 2P, 3P, or 8P is used. Use of these codes is optional for correct coding. And then you have Category 3 codes, or a temporary set of tracking codes used to code emerging technologies that do not yet have any procedure code assignments in Category 1. They are intended to expedite data collection and assessment of new services and procedures to substantiate widespread use and clinical effectiveness. Category 3 code may become a Category 1 code. When it is deleted from the Category 3 and adopted as a Category 1 code, the CPT book provides clear indication of this change by inserting a cross-reference in place of the former Category 3 code. Okay? So for example, 0024T has been deleted. So to report use 93799. The American Medical Association website posts updates this category in January and July of every year. Okay, so again, those are part of those coding rules that is going to tell you what you can code and what you can't code. It's very rare in the coding world that I have experienced, and I can say only I have experienced, that I had to use categories 2 and 3. But I'm just going through that and getting you familiar with it. So in case wherever you work at, in case they have you to utilize that, you'll be familiar with what that is. But it's very rare in my 32 years of experience that I've ever had to use either one of those. Okay? All right, so code book symbols, we'll look at all that. I'll let you look at that. Evaluation and management. So we pretty much have talked about that in a nutshell, basically. So now we're going to move on to the next page. Okay. Consultation, hospital visits, all that is within the evaluation and management. Critical care, pediatric and neonatal critical care, emergency department, moving on to page 166. Categories and subcategories, preventive medicine, okay? And then moving on to page 168, you have the surgery section and coding from an operative report. So let's take a look at that in just a minute. It is best to obtain a copy of the patient's operative report from the hospital when coding surgery. A photocopy can be used so that you can make notes right on the document. When reviewing the report, use a ruler or a highlighter pen. Use the ruler to read the report line by line. Highlight words that could indicate that the procedure performed may be altered by specific circumstances and to remind you that a code modifier might be necessary. Look up any unfamiliar terms using a medical dictionary or an autonomic reference book and write the definition in the margin. Assign the code for the post-operative diagnosis shown at the beginning of the operative report. Also, search the additional diagnosis in the body of the report that you can add as a second diagnostic code to support medical necessity, especially if the case is complex. Okay, so let's look at page 169, and it has a section of evaluation management code. So I want you to read across horizontally. Look at 99201, problem focus. Okay, and then the examination was problem focused. It was straightforward. It was minor or self-limited, meaning it didn't need much attention. I didn't have to spend long with the patient. It was consistent with problems and patient needs and a 10-minute face-to-face. You see how he justified that? So that's how it is going straight across. Now, look at hospital inpatient services. It was detailed or comprehensive. It was straightforward or low complexity. He only had to say, how you doing? How's your fever? Let me take a look at your wound. Oh, you healing okay? Have you passed gas yet? Oh, you passed gas. Well, we're going to feed you breakfast and let you go home. And you don't go home till probably at 2 o'clock. Okay? It's consistent with problems and patient needs. And they saw you for 30 minutes. And meaning that when they saw you for 30 minutes, they saw you for 30 minutes. But it's really 5 minutes, but they spent 30 minutes talking to the other residents about you, okay? Particularly if you're a patient in a teaching facility, okay? So that's how that works, okay? And again, you're gonna get information or feedback from the hospital to say the doctor made rounds today, the doctor made rounds the next day, the doctor, and so when you get ready to bill on your CMS 1500 form, then you have to use a place of service code of 21. And so I'm going to print some of those up for you, okay? All right, so let's move on to page 170. Here's some more. I'm going to keep that going. Go to page 173. Let's see here. Okay, so going to page 173. Okay, now surgical package for non-Medicare cases. A surgical package is a phrase commonly encountered when billing. Generally, a surgical procedure includes the following: the operation, the local filtration. After the decision of surgery is billed, the surgical package includes an evaluation and encounter on the date immediately before or on the date of the procedure. Immediate post-operative care, including dietary, operative notes, talking with the family and other physicians, writing orders, evaluating the patient in the post-anesthesia recovery area, which is like ICU, CCU, SIU, surgical intensive care. Okay, typical post-operative follow-up, discharge or follow-up office visits. Now, remember what I said, that whenever a patient, we'll write it blue this time. Whenever a patient has surgery, okay, they have 3 office visits granted to them for follow-up care after surgery, inclusive of the surgery price. Hint, global package. Okay, global package. Okay, so we're kind of alluding to that right now in this book. Okay. So let's look at the figure on page 173, where it says figure 6-6A, surgical package concept, and B, Medicare global package concept. Okay, so in A, you have evaluation, office visit, or consultation prior to surgery. Then you have operative surgery fee. Then you have local filtration, digital block, or topical anesthesia. They have to put you to sleep. And then they perform the surgery, which is the green. Then after surgery, post-operative, normal, uncomplicated follow-up care. So post-operative means after surgery, you're going to be in SICU. SICU is surgical intensive care unit, okay, or intensive care unit. And then you be there for a few hours. Then they're going to put you where? In a regular room for another 1 or 2 days. Then after they put you in the room for another 1 or 2 days, if it deems necessary to be in the ICU. Then they will send you home. Once they send you home, then that's where the 3 office visits kick in. And they're supposed to be what? For free. Mm-hmm. No charge. It's all part of that package deal. Okay. All right. Now, look at the Medicare global package. Again, you have preoperative office visit or hospital visit the day prior to being admitted. Okay, that's that history and physical. Remember what I said, history and physical must be done prior to surgery. You have 24 to 48 hours to make sure that history and physical is at that hospital before they start operating on that patient. Okay, now they have the operation procedure. The operation begins. Then during the operation, they have anesthesia. They operate on the patient. Now there it is. And then post-operatively, any complication not requiring return to the operating room and 10 to 90 days of uncomplicated related treatment. So they give them time between 10 and 90 days. If there's no complication after surgery between 10 and 90 days, then of that 3-day office visit under the Medicare guidelines, they're okay. Anything that is after 90 days and is part of that previous surgery, then there's going to have to be a utilization review recourse to take place. And there may have to be somewhere you're going to have to really advocate to that patient. Okay, why back in for a similar situation? Did she not heal well? What was she doing, or what was he doing to not heal properly? Things of that nature. Okay, this is after 90 days. They consider that the window between 10 and 90 days because remember what I said once before. When you have been, how can I say, voluntarily assaulted is what we say in the hospital world. Voluntarily assaulted means that you signed to be operated on. You signed to be cut. I'm signing on the dotted line for you to cut me. Oh, y'all getting that? It's kind of like, I'm going to cut you. You do me wrong, I'm going to cut you. Okay? Well, you giving that doctor voluntary right to cut you, right? Okay, so that's what we call voluntary assault. Okay, so once that occurs and you're open in the surgery room, why they keep it drastically cold in the surgery room. When you come out and you're closed, you still are susceptible to infection aerobically, air-wise. Okay, you're still susceptible to infection. That was the word I was trying to get. Okay, so moving on to page 174, Medicare Global Package Policy. So we already talked about that. So make sure you're familiar with that when you get ready to go out there and do that. Now, let's look at lesions and lacerations. Repair that. Remember the other day I barely touched on this, page 175. If a patient has multiple lacerations, I'm reading at the bottom, right on page 175. If multiple lacerations are repaired with the same technique and on the same anatomic category, the insurance billing specialist should add up the total length of lacerations and report one code to obtain maximum reimbursement. Lacerations are considered differently. So some lacerations, if they're considerably long, you can use one CPT code. If you have 2 or 3 lacerations, maybe this is so long and that is so long. There may not be a CPT code for that, so you may have to kind of like measure this one and measure that one, but put the count together to get another CPT code. Okay, that's how you do with lacerations when you're coding, and that's if you're working for a dermatologist that may do some sort of plastic surgeries or repairs to things of that nature, or deal with burns. Okay, so repair of lacerations, and then you have multiple lesions. That's a little bit differently. I'm moving right along. Let's see what time it is. For the sake of time. Yeah, 36. Okay, so now let's look at coding guidelines. In 1996, the Medicare program implemented the NCCI. This initiative involves a coding edit system consistent with Medicare policies to eliminate inappropriate coding of CPT codes. Okay, so now we have what they say. Code editing is a computer software that functions that perform online checking of codes on an insurance claim to detect unbundling. Okay, so remember when I talked about the other day about surgery codes, how 10061 pays at 100% and 10062 pays at 50%, and then 10063 may pay at 25%, and then you may have 1006 this pays at 10%. But some companies, and it just depends, may bundle all of this to one fee instead of paying by percentage. Okay? So they pay one big lump fee for all of that instead of dividing it out by percentages. Okay? In that manner. So unbundling, bundle codes, okay? We'll learn a little bit more about that. Down coding, up coding, code monitoring, office visits, drugs and injections. I'm going to let y'all read all of that. What I want to get to is you all doing some workbook exercises. So let's look at some workbook exercises as time would permit as much as possible. And I think I had some other stuff that I wanted to give to y'all. I have to go back. Okay, so go to your workbook and go to page 87. Page 87. And how many of y'all worked on page 87? Okay. Okay, so these answers to chapter 5, I want y'all to compare that to what you wrote. Okay, here's chapter 5. Here's what you've already worked out. Now, I am going to give y'all an annual test, but I'll let y'all know what's on that test. And again, it'll be open book and time. Okay. Now, let me go to my job to work on that. How many of y'all have worked on chapter 7? No. Chapter 8? No. Okay. All right. So let me give y'all all that good stuff. Oh, come on, really? Now, sorry, took so long. All right, so this is like the answer sheets to compare your information to for your homework. So I want y'all to pay attention to all of that. And when it gets to assignment 6-3, then you're going to have to use the evaluation and management services for coding looks like. Let's see, 6-3. It is. Okay. And then anesthesia problems, 6-4, 6-5 have surgical problems. Okay. 6-6, 6-7, those have some other issues. Now, if y'all don't quite understand how to do 6-3 on 4, then we can work that together on Monday. Okay? Yeah. But try to work this as much as you can, and then we'll work together on Monday. Okay? All right. So this is where I end my video. I have to do some edits here, but I'll have to do that over the weekend when I got some time. All right, and I want to thank y'all for tuning in, and thank you for listening to me, Ms. Harper, on ch.7, and this has been for your health information.
For 6